Hi everyone, good afternoon. Welcome to today's Lunch and Learn. My name is Alexa Carey and I'm the Partner Relations Coordinator for both the South and the West RPUs at Care Compass Network. Before we get started, I just wanted to go over a few housekeeping items. Today's Lunch and Learn will be recorded for quality assurance purposes and may be uploaded to CCN's website or YouTube page. At the end of each of the presentations, there will be a question and answer period. And since we are using Zoom meetings, feel free to place those questions in the chat box. At the end of the presentation, during the question and answer period, please feel free to also raise your hand or just take yourself off mute since we have that capability. I now would like to introduce our first presenter, Cheryl Henninger. Cheryl is the Director of Operations at Community Care's Health Solutions and Geralds Healthcare Center, specializing in community-based clinical service in collaboration with other entities to improve the health outcomes within the communities served. A clinician with more than 30 years experience in the healthcare industry, Cheryl's expertise is in new business development and collaborations to develop evidence-based programs and cost-effective initiatives that promote patient engagement and self-management for better health outcomes. Cheryl has spent the last several years working to develop new chronic care initiatives aimed at the reduction of hospital readmissions and establishing a patient-centered medical home environment. Cheryl has a passion for positive health outcomes and enjoys collaborating with healthcare partners and community organizations, optimizing protocols that are streamlined, yet progressive and encourage active awareness and participation from all. A former accreditation field surveyor, Cheryl also conducts on-site coding and billing audits, as well as overall business reviews in accordance with state and federal regulations and responds to audits on behalf of organizations. Cheryl? Oh, Cheryl, you're on mute. I'm sorry.
Thank you. That's a great introduction, being on mute, right?
That's okay. Welcome.
Thanks everyone again for joining us for today's Lunch and Learn session. Today I'm going to be presenting and taking you through our journey in developing a workforce program to develop a Assistive Technology Practitioner Residency Program. I'm hoping that my puppy stays quiet through the presentation, and I'm hoping that the wind doesn't disrupt my connection here this morning as well too. And I'm hoping that I can work the screen because it's not advancing for me. There we go. So just a little bit about Geralds Professional Pharmacy. Geralds Professional Pharmacy is dedicating to remaining a long-term stable community provider. We are a third-generation family-owned business, and we've been serving the community since 1921. So this is our 100th year anniversary. We also decided a few years back to diversify and take an active part in healthcare reform to further support our communities, to improve outcomes and create new revenue streams. In 2014, we started expanding service offerings in the geographical territory. In 2018, we participated in the Elmira Downtown Revitalization Project to invest in modernizing the oldest and first location for the enhanced accessibility and expansion of services. We continue to see ourselves as an industry leader and advocate diversity and change. And we're most interested in creating new avenues of community care that can become reimbursable and help others to all do the same. I also wanted to note that our Geralds owners and board of directors take pride in their family heritage, and they're careful to make sound business decisions and investments. Getting out of the musical world is something many of us take for granted. For those of us who have physical difficulties, a curb, a few stairs, or moving around in the home can be difficult and very risky. Assistive technology professionals work with the aging population and the disabled to provide home safety, mobility, and accessibility products to help people remain in their homes and reduce the risk of falls. The growth of the aging and disabled population is rapidly outpacing the assistive technology workforce. This is creating a gap not only in the Care Compass Network region, but also across the nation. This creates a barrier to care as the aging and the disabled are less apt to be able to obtain medically necessary mobility and accessibility items that could be covered by insurance. Assistive technology professionals evaluate the technology needs of people with disabilities and help them select and use adaptive devices that are most appropriate to them. So we're looking to fulfill a workforce gap for servicing the disabled and aging. We were looking to fulfill the need for medically necessary mobility and accessibility products and services. And through this workforce program, we've been able to offer varied certification paths, such as for assistive technology professionals, who are the ones that adapt, create, mold, and build customize assistive technology and wheelchair systems. The assistive technology technicians that assist in the electronics and repairs and maintenance of these devices. CEAC certifications that are certified environmental assessment consultants that are trained to evaluate home safety situations and make some recommendations. CAP certification also, which is a clinical end of home evaluation. And the DMERT level 1 and 2 certifications, which are really medical equipment technicians, and the levels are differentiated by basic and advanced. The average age of today's assistive technology practitioner and workforce is 52. The age of the average American worker is 42. 3.4% of the industry's ATPs retire each year, and the incoming rate of ATPs is only 1.8%. So the complex rehab technology industry is also growing at a rate of 4.8% per year. Geralds is the only company in a 9-county region in New York that employs AT staff, including an AT. Geralds is also the only certified provider for the New York Nursing Home Transition Diversion Waiver Program and the Traumatic Brain Injury Waiver Program that covers the southern tier of New York. More certified staff is needed in the area to accommodate the mobility, accessibility, and home safety needs of the aging and the disabled in the area. In 10 years from now, there will be twice as many people over the age of 80 in the United States as there are today. Statistics also show that an overwhelming percentage of this population will want to continue to live in their home as long as possible. This is not only the lowest cost alternative for people, but the barrier is that many homes are not safe enough today, and it's estimated that only about 3% of homes are designed for safe living for the older consumers. So when we did the application for the workforce pilot program, CCN had defined some workforce pillars that we wanted to make sure that we aligned with. The goals of the workforce pilot was to optimize care and services for the elderly and disabled that were in need of assistive technology products and services, as well as home modification products and services. The goal was to develop a sustainable program to increase recruitment and provide the specialized training and education to increase the workforce, not only in the CCN service area to meet the diverse needs within the region, but also our long-term goals were to work on a national level as well too. In collaboration with US Rehab, DMER, and VGM Live at Home, Geralds Professional Pharmacy has developed an Assistive Technology Professional Residency Program to provide necessary hands-on skills. I'm going to talk about each of those organizations a little later on. Training and complementing the online training programs provided by DMER and VGMU. Our collaborative program also seeks accreditation and financial aid eligibility to lessen the financial burden on students and employers looking to retrain or redeploy current workforce. Historically, people have been groomed through years of on-the-job training for these positions. Companies providing these services are reluctant to spend the money to train staff, redeploy into these positions for a couple reasons. One, the skill sets required are unique and not everyone is successful in completing any of these levels. Another thing is because of decreased reimbursement, putting that investment into a staff member, it's just a very fine line. Certification and training programs are available online. They are time consuming and they are costly for those who want to advance into this role. In addition, the online training for this career path in itself is not adequate. It's adequate to prepare for the certification test, but it really does lack a lot of hands-on training that's needed for employability post-licensure and certification. So to enhance the training experience, the program seeks to establish community service clinics in which people can bring their assistive technology devices for general maintenance and tune-ups. And I'll talk about this a little later too, but as with everything else, COVID has delayed this part of the program just because of social distancing and the risk that's involved with that. This career path as an ATP or an AT assistant or any of the other home modification certifications has not been marketed to young people who are graduating from high school. And the career path is also not emphasized in PT and OT trainings as it doesn't require an advanced skill set of a physical therapist or an occupational therapist. It is, however, a great fit for a physical therapy assistant or OTA program, and there are technician and professional levels of certification available. So the goals of this project were as follows. One, to create a local residency site in collaboration with the organizations listed to provide the necessary hands-on training that was required for students to master the skill set upon completion for enhanced employability. The second goal was to establish wheelchair clinics in which students can have more hands-on experience with equipment maintenance and servicing. This is also a way to provide free community service to help patients maintain their equipment. So that it would extend through the reasonable, useful life of the equipment. The third goal was to submit an accreditation application in collaboration with the organizations because we know achievement of accreditation for this program would allow financial aid recognition. Which brings us to goal number 4 for financial aid recognition to help students by reducing the financial burden of having to pay up front for training. This also helps employers who want to redeploy staff or hire staff and then put them through training. Students would be able to obtain financial aid, and once licensure and certification have been awarded and competency is established, employers could potentially offer tuition reimbursement as they see fit. We also wanted to be the first residency site that can be duplicated not only throughout the state, but nationally once it's established. There were some additional goals. One was to ensure that those with disabilities could obtain proper medical equipment and services that meet their needs. Reimbursement dictates medical necessity over many of these products, and there is extensive documentation and assessments and evaluations that need to occur to prove medical necessity for those who are disabled. As I mentioned before, we also wanted to ensure that we extended the lifetime of the product by ensuring that we provided the equipment with maintenance and proper safety checks and making sure that the individual was using them appropriately and caring for them appropriately as well. Obviously, we want to increase the workforce that's needed to evaluate home safety and accessibility for the aging population and the disabled. And we also want to decrease ED visits and hospitalizations due to falls because of lack of proper mobility and accessibility products. Some interesting facts that I thought would be great to share. In the state of New York, it's estimated that 2 older New Yorkers die each day because of a fall. It's also estimated that 140 older New Yorkers are hospitalized every day due to a fall. 223 older New Yorkers are seen in emergency rooms every day because of falls. Therefore, we're spending $1.7 billion in annual hospitalization charges for these patients, $145.3 million in annual outpatient emergency department changes. Approximately 95% of the hospitalization charges are billed to Medicare and Medicaid. So therefore we're using government funds to care for these patients. 60% of those patients over 65 end up in a nursing home or rehab center after a fall. 11% of these suffer a traumatic brain injury, and 27% of those over 65 experience a hip fracture. So as we all can see, and as we all really know, falls can result in lasting serious consequences that affect mobility, and they cost a lot of money. Additionally, I thought it was interesting to point out that there are 3.3 million wheelchair users across the nation. And we all know, because of the baby boomer increase, this is estimated to grow significantly over the next 10 years. So you can imagine what this is going to mean to healthcare expenditures if we don't step in and try to do something to reduce the risk of falls. So previous experience was something that was asked upon the application as to how we thought we could handle this. So at Geralds, we've been an intern site in the past. We've hosted students from Elmira Business Institute for medical coding and billing. We also host OT students and a variety of other students for shadowing. We have staff that has served in clinical instructor roles in the past. Some of our respiratory therapists, our division lead for our rehab division, managed a rehab center. So he also managed students coming through the rehab center for PT. We also have experienced staff in accreditation and surveying. And as I stated before, what Geralds is really proud of is that they're very diversified and are always looking to be innovative to develop new business lines. So let me talk a little bit about our team resources that we linked up with. US Rehab is a group of credentialed complex rehab equipment providers that work to provide members with education, regulatory support, vendor support, and reimbursement assistance. US Rehab has really been key in assisting us in providing regulatory support and connectivity with some of the certification programs such as NCART and RESNA, who have really supported this program. The DMERT Group is a nonprofit certification body that's tasked with setting the benchmark for complex rehab and complex repair training standards through industry collaboration. The mission of the DMERT certification initiative is to engage all interested industry members in establishing a clear set of guidelines as to what can be expected of repair technicians and ATP professionals and within the industry. DMERT has an online training program that has been established, and we use that as our online training program. They have also created a master's program for our workforce program so that all of our curriculums and competencies can be facilitated and led by our staff. So we have master trainers established for this program because of what they've done for us. VGM Live at Home is a nationwide collaborative membership community with services and solutions for independently owned and operated certified accessible home modification providers and contractors. I know that's a mouthful, but for those of us who are certified to do home modifications, they're there to support us. They provide industry support, and they've worked with us to develop this residency curriculum, and as well as competency assessments that will complement the online training and CEAC certification and testing requirements. I also wanted to mention that our discussions as far as setting up the wheelchair clinics, we really had good response from several potential clinic sites. In particular, Elcor and Horseheads, their rehab department was extremely interested, and we have really done a lot of brainstorming with them. Other nursing facilities also stated some interest, as well as Care First also stated interest in providing their location as a site for a wheelchair clinic. And as you know, of course, of COVID, we've had to put that on hold. So the timeline we had developed was that we would start by January 1st of 2020 to build the program. We actually got started January 9th because of contracts. We were projected to be operational by January 1st of this year. We actually were operational and started training sessions in September of last year. Our initial residency completion was projected to finish the end of June of this year, and we are on target to meet that deadline as well too. We also, within the timeline that I didn't list here, we projected to have an expansion plan in place by the end of September of this year. We'll be able to embark on some of that, but we do have some challenges that I'm going to go over in a couple seconds too. So the challenges have certainly hit this project, as with most services, due to the pandemic. Geralds and DMART are now talking with local colleges regarding the addition of this program as a certification program under one of the college's accreditations. We anticipate that if agreed upon, it will take 9 to 12 months to complete that process, recruit students, and start the first formal cohort. Serious discussions had to take place with US Rehab to get them back on track regarding accreditation. Their vision of accreditation was different than ours. We initially wanted to develop our own program with our own accreditation, which still may happen if it falls through the colleges. It'll just mean a longer timeline to complete that goal. But we are dedicated and working toward whatever we need to do to achieve accreditation, to offer financial assistance, because we really do feel that that's key. I will say that they're certainly very willing to help us connect with local colleges, which we feel is going to be better locally for our community also. And this added certification program would be a good fit for students in some of the college programs, such as Broom's OT or PT programs, because it would certainly bring diversity to their career paths. Again, the wheelchair clinics, we also talked about that as well too. And just overall collaboration, as we all know, as we've collaborated together, sometimes we have differences in how we view things. And sometimes it takes a little bit longer to work through those challenges and make sure that we're all on the same page. So we've also gone through that as well. Accomplishments, we have 4 CEAC certified staff now. We also have 2 technicians that have completed DMART level 1 training, and they're both enrolled in the DMART level 2 training. We have 1 person who is enrolled in the ATP training, and actually that person will be sitting for their certification test in the next few weeks. Additionally, beyond these baseline goals that we wanted to accomplish as far as certifications, we were able to establish master trainers so that we're able to facilitate the whole program, including the online classes and the residency program together. We also have staff that achieve CAPS certification, which is similar to the CEAC certification, but it's more in depth, and it's meant for those with a clinical background. And we also found a need for those with the disabilities also sometimes need some custom bracing. And we had received a lot of feedback within our community about the barriers and gaps as far as patients being able to obtain custom bracing. So we do now have certified custom bracing fitters. So we're able now to do some custom bracing as well too, which does align with the program also. Next steps, again, we're working toward accreditation and financial aid. Once the pandemic, once things are opened up, we'll be pursuing the wheelchair clinics, and then we'll be looking to increase recruitment and then expand the program from there. And that's all. Does anybody have any questions?
I do. Could you just address briefly the reluctance of the workforce to participate in this program?
Yeah, so I think there's a couple things. It's always, these positions have always been only known within the DME industry or the home medical equipment industry. So it's not really highly publicized what people do and what the needs are to obtain these types of products. Until somebody needs them, they don't understand what they have to go through. But these products are highly governed by Medicare and Medicaid. In order for them to be covered, we need to have licensed professionals to do this. And it's such a select group of patients that, again, within the DME industry, it's just always been held within there. It's never really been publicized as to what these career paths are. So it's hard to go out and explain to high school students because it's so specialized. It certainly is a career path. It doesn't require a college education. These certification programs can happen outside of a degree. So as companies have recruited for these positions in the past, you can't really just bring somebody in and have them start on the job training. It's a 1 to 2 year process depending on the position that you're trying to fill. So a technician position is about a year once they go through all the certifications. To become an ATP or Assistive Technology Professional, who actually evaluates, measures, configures specialty wheelchairs and other types of specialty items, it's a 2 year path to do. So I don't know if that answers your question, Lenore.
It does. Is that more significant than the level of pay or the perceived job opportunities?
I think, from a pay perspective, it's pretty, it's certainly, it's between a PTA and a physical therapist. So from a pay perspective, it's a fairly decent pay grade for the ATP. For technicians, it's around a PTA pay grade. So, it does require someone that has a very good mechanical ability. It also now, with the highly advanced technology and electronics in some of these devices, it does require electronic ability as well too, electrical ability. So looking at schematics and stuff like that, so it's a very unique position. And again, if you're looking for somebody to help with home modifications and look at patients' needs in the homes and configure wheelchairs, it is very beneficial to have a clinical background and to have good people skills and be able to work with people who are disabled and in need. Does that answer your question, Lenore?
Absolutely. Yes, thank you.
Sure. Any other questions?
There aren't any other questions in the chat box, but if anything does come up, oh, Sally, go ahead.
First of all, I just want to say this is a great program. For those of you who might not be aware, that if you have someone who's coming home from having had a traumatic brain injury, and they're being released and discharged to home, they can't even take a shower until the house is modified with a special shower unit, a special shower chair, just entryways. It's not just the ramp. It seems like the ramp seems to be the easiest part. You can get a bunch of neighbors get together and build a ramp. Everyone's willing to do that. But, vans that not only need to be modified, but also need to be maintained, and all of this, it makes such a difference. I always tell people that, one area rug, life has changed. You put one area rug in the wrong spot, life has changed. But also in a blip of an eye, it can change. And the services that you're providing are so crucial. And yes, the regulations are, it's such a quagmire to get through. So to have someone to help navigate through that is just, thank you very much. It's a great program.
Thank you, Sally. That's very, very kind of you.
I don't see anything else in the chat box, but like I said, if anything does come up, please feel free to add it to the chat box. Thank you very, very much, Cheryl. I really appreciate it.
Thank you. Thanks for the opportunity.
Of course. At this time, I'd like to introduce our second presenter. Sharon Chesna is the Executive Director of Mothers and Babies Perinatal Network, a regional community-based health and human service agency focused on the reduction of maternal and infant mortality. She has had 30 years experience in the field of perinatal health, including healthcare planning, program development and advocacy, obstetrics and gynecology, practice management. Sharon has been honored by serving on many national, state, and local boards of directors and advisories, and has been a part of numerous research studies related to perinatal health services and systems in the United States, New York State, and at the regional level, and has been contributing author for a number of studies and reports on various perinatal health topics. Sharon completed her academic studies at Binghamton University, receiving a bachelor's degree in business administration and a master's degree in public administration and healthcare. She is married to her best friend and lifelong partner, Joe. They have 2 adult sons and 4 beautiful grandchildren. She loves spending time with the family and friends and thankful for all the opportunities she has had. Welcome, Sharon.
Thank you. Hi, everybody, and thanks for being here today. So hard act to follow, Cheryl. You had great information and really a nice job on that. So our project that we did was really to look to improve the capacity of our staff internally within community-based organizations so that we could be really strong partners as all of us move forward for healthcare transformation. CCN's RF, the request for proposals for this came out in August of 2019. And again, their goal was to encourage any of the partner agencies to, brainstorm and to have the opportunity to implement any sort of transformative, initiatives, activities that could address any of the workforce issues highlighted here. What I've highlighted for you here is the 4 that we chose to address in our proposal. So education was the really key piece here, education and training for our staff. We've been very fortunate to be able to retain a lot of our staff, but we want to be able to continue to build retention because, of course, it builds the strength of our organizations, and then also to craft workforce collaborations. So our very first collaboration on this is the fact that this was a collaborative initiative from the very outset between Mothers and Babies and Rural Health Network. And I do want to acknowledge Jack Salos is on here today, as well as some of his staff. So I'm going to encourage Jack to jump in if he wants to add anything. But he and I and our agencies have been, strong partners for many, many years, and we have learned from each other. We have developed programs together, and it's been a wonderful relationship. So he and I were talking as the RFA came out, and initially not necessarily thinking that it was, specific, something for us. And then as we talked more about, both the size of our agencies, being that we are, mid-sized, small to mid-sized community-based organizations. We've both been fortunate to have staff who have been with us for a while, but we also know that, we're not going to be here forever. And so we wanted to make sure that we could put plans in place for our agencies to begin to increase the skill set for our current organizations. So our plan was to provide leadership training for our program directors and managers, and then to implement an introductory personal development training program for our mid and line staff, selected numbers of those. And then finally, as a sustainability initiative, we were intending to create an in-house mentoring program, starting with the group that we've worked with over the last year, and then to move beyond that for all staff education and development. Just going back, so thinking about it, I think we all hear, and again, as community-based organizations and, even with hospitals, any large entity, people are always talking about succession planning. That can be particularly difficult in small to mid-sized organizations. And so we think of that oftentimes as if the executive director, in our case as CEOs or CBOs, are going to leave, then boards of directors are very concerned about, what are we going to do? Are we recruiting outside? Are we building from within? So it's oftentimes just at that top leadership. But the reality is it really needs to be a program that's much more comprehensive. And that's where I think that when you take the concept and move it from the planning to management, it's really putting in place, a model in order to ensure that we do have, a pipeline for our staff to grow in their own initial skills related to their current positions, but also to identify those that have some goals for upward mobility and want to increase their skills. So I do think there's just that little bit of a difference between that. So our plan design was to first and foremost retain a consultant to provide this leadership training and personal development for our staff. And following that, the plan was to work with our program directors and managers, a total of 12. Again, very much a split, initiative between Mothers and Babies in Rural Health. So 6 from each of our agencies for a 6-month program, which included the group and individual sessions. And then following that, to then identify an additional up to 6 members per each agency of mid or line staff, who again, we've identified for potential future opportunities. And as I mentioned before, establishing that mentoring program. We are really thrilled to work with Ruth Henninger, who is a independent coaching and consulting small business on her own. She was very, very helpful in helping us actually put the RFA, the proposal, together. She provided a lot of consultation during that the application process. And then it was really, from her expertise that she really mapped out that detailed development and the topics that would be addressed for both plan levels, and then working together, her initial concept of the mentoring program, and then, with Jack and I, we sort of fleshed that out more towards the end of the program. I should point out that while Cheryl has talked about their initiative being, I think, over a longer period of time, it sounds like at least 2 years, we propose this for a 1-year period, really just for the calendar year of 2020. Ruth was also instrumental in helping us with all the reports that we needed, not all, but a couple of the midterm and final reports we needed to submit to CCN. And she's really been amazing, because beyond our contracted period of 2020, she's continued to work both with Jack and I, and then to also have post-contract follow-up with all the staff in the program, providing them sort of an additional follow-up and mentoring. So this sort of just shows you where our plan, how we laid it out. So our first level of leadership, which again for the program directors and managers, included both monthly group sessions for a total of 5 of those, and individual sessions where Ruth would work with each of the 12 people in the program and met with them again once per month over a 5-month period to help them transition some of the tools that they had gained from the group trainings, put those into practice, and then to set individual goals and how they would move forward with actually striving to achieve those. So our second level of training, again for our mid or line staff that were selected, modeled, you can see the correlation between the topics for the monthly sessions. But of course, since the majority of them were not supervisors, we replaced the change management and motivating others and incorporated the goal setting and project management skills. It was not initially planned in our proposal to CCN, but Ruth, following the group sessions, offered to provide each of the staff members in this level 2 program with a single individual session, which again was highly valued by all of those. So again, our initial plan with the mentoring program, that we did sort of lay it out when we talked with our directors and managers, that they would agree to act as mentors for the individuals who were in the level 2 program. And then following the conclusion of the level 2 training, each of the level 2 staff members were to select a mentor from the first pool. And we worked through the concept of the program itself. And that would occur for 6 months. And that again is really the, I'd say, initial part of the our plans for sustainability. So looking at some of the outcomes, we did have 12 of our program managers enrolled, and all 12 completed the program. The group sessions, as I mentioned before, were fully intended to be in person, and only 2 ended up being held in person because, of course, the pandemic, hit us in March. So the last 3 of those were virtual, and that was definitely a transition and a challenge, I think, for the staff members who had the experience of the in-person and then were forced to move to the virtual. Following those sessions, we did ask them, to evaluate the program and look at each one of the individual sessions. And so the idea was that, the 3 was the highest rating regarding relevancy and application to their position or their program. And it all rated out very well. you can see the numbers here with each one of those sessions. The individual mentoring sessions, again, as I mentioned, they were over a 5-month period. Each individual had at least an hour, and I think sometimes longer, one-to-one session with Ruth. And once again, they all had to be done virtually due to the pandemic. But when we look at, while everyone set their own personal goals, we aggregated those for our report back to CCN, and you can see here that it was, increasing or enhancing their communication skills, how to do a better job of engaging their team, the individuals who work for them, looking at long range planning, which again is vital for a lot of what our goals were as organizations. And then again, working collaboratively and building on their own leadership styles. The leadership training level 2, if you will, was for, again, our line and mid-level staff. 12 were enrolled, but only 10 completed the program. 2 individuals left employment prior to the completion of the program. They had 4 group sessions. All were held virtually. Again, had initially been intended to be in person, and they had to be done virtually. Their evaluations are very similar. All of the sessions were highly rated. And the goal setting and project management, again, which sort of were replacing the 2 in the first level, were actually one combined program together. And everyone, was very pleased with the information that they learned from those. And again, as I mentioned, Ruth did offer to provide an individual mentoring session with each of the individuals. And again, in general, they focused on communication skills, greater competency in their job, and thinking very specifically about their own programs, so achieving those goals and objectives. And I thought that I would just share like a comment from our first group. Overall, the coaching evaluations were extremely positive. Everyone appreciated having an impartial person, who was available to discuss their leadership challenges and to support them in taking their best course of action. They also acknowledged that it did require time, both the time invested in the program and then the time to really think about, what they had learned through the various sessions and to be more reflective about some specific challenges. And really start to put a plan of action in place rather than just putting those on a back burner. And when we take a look at this level 2, some of the comments from staff included appreciating, the concrete strategies that they could incorporate to improve, particularly again, the whole piece with respect to communication and how to communicate with people with varying, personalities and things like that. So overall, very, very positive. So our mentoring program, and let me stop for a second and say that when we did both the first level of training and then the second level of training, they were joint sessions. So all mothers and babies and rural health staff were together for those group sessions. When we looked at the mentoring program, those we actually identified as they would be better done by each agency individually. So again, we worked very closely, Jack and I worked closely with Ruth to outline the model for the program and then to work it within our agencies respectively. So our time frame again was 6 months for this one, and that began just at the beginning of this year. All of that level 1 and level 2 training concluded at the end of 2020. And so right around the early part of December. So that's why we said we'll just wait until after the first of the year to initiate the mentoring program. So part of our expectation of our program directors and managers, even at the outset of the training, was to ask them to commit to being a mentor. So we had a total of 12 individuals who agreed to be mentors, and of the 10 mentees who had completed the program, each one would independently choose their mentor. We had some discussions with them and let them know they did not have to choose their supervisor. They, could actually choose to work with someone for whom they were not a direct employee. And it was wonderful to see the mentees, how they did select a mentor. As we tried to flesh out the program, we had initially, Ruth had initially offered a general set of expectations of what the mentoring sessions would accomplish. And then we felt that it was necessary to actually provide a set of guidelines, both for the mentor and the mentee. So those have been developed, and actually, all of this is available to share with other organizations if they're interested. And then we had a mentoring agreement form that both individuals, both the mentor and the mentee, signed to recognize that they would follow those guidelines and that they would commit to those 6 months. So as I mentioned, it just began in January. So we are, hitting the midpoint right now of the mentoring. And, so far, Ruth actually just conducted an assessment of the mentees, I think it was about a week and a half ago. And in general, all mentees are feeling very positive about the program. And 2 of them actually requested an additional coaching session with her, to which she has agreed. And I thought it might be nice to share a comment. So I have one staff member who had shared with Ruth that she felt she was really doing well, and the mentoring sessions were wonderful, that she felt she was learning a lot from her mentor, and she had also narrowed down on the goals that she had initially set up. So she was very pleased with that. And one of her key goals had been about communication. And she feels that that's still a very important goal, but she now feels that they've been able to narrow it down to like situational awareness type of communication. That's her term on there. And basically my mentor is teaching me about how to confront and deal with difficult people in different types of situations through her own past experiences, and what to do now in the present or in the future. And another individual had commented that they were really enjoying the entire mentoring process, really enjoyed meeting with their mentor, and feeling that she was definitely benefiting professionally. And has already indicated that they'd like to continue this beyond the 6-month period. And one other individual had indicated that they've already achieved or reached one of their goals, and feel that everything has been really going on track with the mentoring process, and helping to move toward the rest of her individual plan. We did have some unanticipated outcomes. And you can see here that a few of our staff acknowledged feeling, these are the positive ones, more confident in addressing conflict or potentially difficult conversations, particularly with staff that they supervised. Some definitely stated that they felt more empowered to be leadership within within the agencies for whom they're employed, and identified in a way of improving in their mentoring or their supervising of their staff by approaching it in a more of a coaching model, as opposed to a talking or a dictating model. The tools that Ruth used, many people were extremely happy about those, with both the DISC assessment and the transformational leadership assessment that comes out of Clifton Strengths. And we'll talk about those for another minute. And but our negative outcomes, obviously, part of that was pandemic related, especially for the first group who had the opportunity to do the in-person meetings to start the project with. We're very disappointed to have to move, obviously, into a virtual meeting, and it definitely impacted both review from the consultant, that it definitely reduced participation and probably to some degree the level of learning achieved. And the staff themselves, agreed that it was just very challenging to have that done in a virtual fashion, and definitely limited, discussions and things. And of course, everybody, I think we're all feeling Zoom fatigue pretty much all the time, but definitely it was one piece expressed in the evaluations here. And then one recommendation moving forward is that staff did indicate, while they enjoyed meeting their colleagues from the other agency, that in the future they think that this would be better done just within their agency as opposed to in the partnership piece. We did find that 2 of the management staff who completed the program had not really felt that it was terribly beneficial for them. But again, they had been long-term in their positions, and just didn't feel that it was as essential as it did for other individuals. All of the midline line staff who completed it were really excited and very appreciative of the program, and really honored to have had the opportunity to attend. What Jack and I both did was, prior to implementing the second level is we worked with our program supervisors to get their recommendations of what staff they thought had great potential and might be the ones best suited for this level of training. So it was a collaborative between us as the directors and the supervisors to make the selections of the staff for that program. And both Jack and I feel that this has really helped us to helped staff appreciate their positions and roles within the agencies, and I think feel more valued that they're looking at, you know, advancement. Some short-term outcomes that I think we've seen already is definitely a change and improvement in those directors and managers and their supervisory skills. Again, we feel, I think I just mentioned it, you know, how much they're really appreciating both their roles within our agencies and what opportunities, and I guess to think how we're valuing them. So everyone is very much embracing the idea of the mentoring. I have a feeling that would happen at some point. And they're all really expressing a strong willingness to really work as a team together. So it really has been, in the very short term, very positive. Some of the lessons that we have learned is that not everyone is seeking to advance. They want to become more proficient in their own position. They might want to have, say, a mid-level advancement, but not necessarily be taking over, for example, at the agency or the ED level. All of our staff in the level 1 training were interested in the training, and they were feeling that their competency, somehow I've got my words wrong here, but their competency was adequate, or because they were looking to wind down in their careers. Those are the staff, you know, who we were surprised that didn't value the program as much. So I think in a lesson learned and, you know, a recommendation for someone wanting to implement something like this would be really to see ahead of time, you know, where someone's individual goals are for their future career path, or what the window, the time frame might be for that. Our consultant did, note to us that the engagement of the line and the mid-level staff seemed to be a little bit less. They were a quieter, more introverted group. And this, I thought, was a very good lesson for us as directors, that many of them were not familiar with some concepts such as a SMART goal, or even how their work, their current position, is a part of the project for which they're hired. So, we're really saying now that we understand that we have to help them understand or give them bigger pictures. So, for example, with a lot of our programs being contracts with New York State, specific grant funded programs, helping them to, or presenting to them the proposals that we've actually put to the state, looking how those contracted outcomes or objectives that we've agreed with the state on, where they are, and then how their work fits into that. So that's definitely a lesson that, that we have learned. And so that was really an outstanding piece for me. As I mentioned, with the DISC assessment and the leadership assessment, I found those to be, amazing tools that I honestly had not been familiar with ahead of time. So we are now looking to integrate those into the agency on a broader scale. Both within each of the departments, if you will, and then also even into orientation after staff are newly hired. A couple of the comments, from the program is that I found this reflective practice to be very helpful, allowed me a space to understand and articulate ideas and feelings that I may not have fully formed. The coaching, again, you can see here, gave us a chance to explore new ideas and what works best for us as leaders of our teams. So again, very, very positive outcomes for the program. We could not have done this without our consultant, and Ruth was probably the very best consultant that we could have selected. And this is Jack's comment here about, again, her training program organized, and she truly is an expert in her field. And we both really appreciated, how she helped us to both refine the approach, use the tools, the mentoring, and actually the discussions that we had, throughout the entire, 12 plus months of the program. Jack has indicated, his plan is to possibly continue to work with and engage with Ruth beyond this contract, using, her expertise to help with other staff, and then possibly ongoing training for the people who've already completed the program. And, I again felt that the materials that she used were really wonderful. And as I just mentioned, I'd like to continue to see that we can incorporate those, into future, training and orientation of staff. There's a cost to those. So that's one of the challenges at looking at this overall. So I would definitely like to say we have sincerely appreciated CCN's confidence in us in the funding to implement this program. Obviously, Jack, from my perspective, is an amazing partner and a collaborator. And as I mentioned already, Ruth has been fabulous. And we really want to acknowledge our staff. As I said earlier, they could choose not to do this. They spent a lot of time doing it, and even outside of the groups or the individual sessions, they had to complete these online assessments. They had reading to do, so it was a little bit of homework before some of the sessions. So it definitely took time on their part and commitment. So I just want to acknowledge them as well. And that's it. So if there's any questions, I'm happy to answer them. Or I'm sorry, Jack, I'd love it if you wanted to share a comment or two.
Unfortunately, he had to leave the meeting. Sharon, this is Pam.
Well, and actually Pam and a few other staff are here who completed the training. I don't know if you'd like to share anything.
I'll just echo what Sharon said. I think, so I was in group 1 and made that pivotal shift because of the pandemic. But I can tell you when we got to the one-on-one supportive coaching sessions with Ruth, it could not have happened at a better time. It really was a true gift during the pandemic, and it was that extra level of support to really help us, because all of our teams were pivoting and doing new projects and new deliverables on top of doing their current job. So it was incredibly helpful to have that extra level of support, and like Sharon said, that outside view looking in.
Mm-hmm. And I think our Cindy and Mary are also on today, and actually Courtney, hi, I see you. So they all had a chance to participate in the program as well, if they'd like to share.
Yeah, I would echo, pretty much everything you said, Sharon. Every comment I thought of, you said it. And then what Pam said too. I would agree that the one-on-one consulting that we had with Ruth after the group sessions was especially valuable. But I think one of the most valuable things that came from the group sessions were those assessments that we did, where, it was great to kind of use those to learn about ourselves, but then also to think about the different styles that our coworkers and colleagues had and used, and to be able to sort of get a better picture of the best ways to communicate and the best ways to observe and the best ways to listen to people who had different styles than we did. I found that particularly valuable. And now in the next stage, I'm mentoring one of the midline staff that participated in the second round. And again, just as I'm getting I think I'm getting as much from that as she is. So yeah, it's been a great experience so far.
Thanks. Cindy, did you want to add? You're muted.
No, I'm not, I think. I agreed with almost everything you said, Sharon. I probably was one of the people who did not say that I would have rather have done this only with our own agency. I actually thought it was really helpful, particularly at the beginning, to have a group of staff from both organizations, because we came at things with different perspectives. And I think we learned from each other because of that. I do agree that towards the end, as we started to develop more personal goals, it could have been helpful for some of the later sessions to have been divided just at the own agency. But I really liked when we were meeting in person together with both organizations. I'm also one of those people that view myself as towards the later end of my career. And I had worked with Ruth in a prior life or prior professional life. So I had done a couple of the activities that she engaged us in prior. It was really interesting to see whether or not my strengths had changed over that 10-year period. And some of them had, actually. So that was sort of interesting as well.
Thanks. Courtney, I didn't know if you want to share anything. I know you weren't able to complete level 2, but I leave that to you. Perhaps not. So is there any questions? Okay. Well, again, we want to thank CCN for the opportunity to conduct this leadership development in our agencies, and I'll turn it back to you.
Thank you so much, Sharon. I really appreciate both you and Cheryl presenting today. We are right at time. So again, I will thank everyone for joining us. As always, there will be a link that is sent out to direct you to a survey based on today's Lunch and Learn. Again, thank you very much, and I hope you have a great rest of your day and a fantastic weekend. Take care, everyone.